welcome back to my channel. My name is Gia. I'm your friendly family nurse practitioner, and today I am very excited to talk to you about chronic abdominal pain. And because you know, chronic abdominal pain is a common complaint in primary care, and the differentials can be very broad. So I hope that this presentation will shed some light and help you navigate through helping your patients that come in your clinic for chronic abdominal pain. And by the way, my reference for this presentation is the 5-minute consult and also my experience. All right, let's begin. So chronic abdominal pain, like I already mentioned, because the differential diagnosis can be very broad, it can feel overwhelming. But like I said earlier, I hope that you feel comfortable with taking care of your patients who come in to see you for chronic abdominal pain. Okay, so description. So chronic abdominal pain is defined as more than 6 months or 6 months or more of persistent or intermittent abdominal pain. As you can see here, there are different regions in the abdomen, and so you just have to familiarize yourself with the different body parts, not body parts, but different organs in each quadrant. Okay, and that is important. So what are the common causes of chronic abdominal pain? So these are the common causes of chronic abdominal pain: irritable bowel syndrome, functional dyspepsia, GERD, IBD, PUD, PID, and abdominal wall pain, and celiac. You also want to take into consideration any domestic violence or history of incest or rape, or a history of anxiety. All right, so what are the red flags of chronic abdominal pain? So as with any complaints, you want to make sure that you rule out or you consider the red flags, for prompt evaluation and treatment of your patient. So these are the red flags. So anemia, GI blood loss, weight loss, dysphagia, fever, and if the onset started when the patient is 50 or more years of age. So your workup is going to be CBC. You're gonna do ESR, CRP, so liver function test, your the TSH, lipase, anti-TTG, and you can consider PPD, stool kayak, Giardia, HIV, C. diff. This is depending upon your history and your physical too, and in any risk factors. Your imaging, you're gonna do some, because of the red flags here, you're gonna consider upper or lower endoscopy, and you can consider CT scan. Okay, now I want to mention a screening for intimate partner violence. This is important too, especially if you work your patient up and there's no identifiable cause. So you make sure you do this. And we also screen for intimate partner violence when we do our wellness visits or physicals. So for history, you can be comprehensive depending upon your time. So you want to do your old card and associated symptoms. You want to ask for any nausea, vomiting, diarrhea, constipation. Like I mentioned, dysphagia is a red flag symptom, bloating, early satiety, anorexia. And for your physical, I would encourage you to do abdomen, heart, lungs, and also your GU. Some GU condition can cause abdominal pain, right? So if the patient is complaining of dislocation, specifically in the lower abdominal areas, in the right lower quadrant, left lower quadrant, make sure you work up for STI. You can do pelvic exam and transvaginal ultrasound, and then treat accordingly. For follow-up, if you've already, your workup came back negative and the patient's still coming back to you for persistent symptoms, I would encourage you to do a, lead risk assessment, assess for any gluten intolerance, consider lactose intolerance, and hypercalcemic risk factors too. So your workup, or my recommendation for this, if you're considering any intolerances, you're gonna do dietary modification based upon which one is it that you're considering. It encourages patient to do a food diary, and you might want to work them up for finding out if they have celiac. So do your anti-TTG, check for calcium, lead level if you found them to be at risk. So for hypercalcemic risk factors, so risk factors for this include your primary hyperthyroidism, certain cancers like multiple myeloma, medication such as diuretic, right? The thiazide, kidney disorder, bone disorder like Paget's disease, and endocrine disorders like adrenal insufficiency can also contribute to hypercalcemia, and any vitamin D disorders, dehydration, and prolonged immobilization, right? And so for your lead risk factors, you're gonna ask them about their occupation. Are they painting? Do they do some mining? So lead-based paint can be found in older homes built in 1978, and that can deteriorate over time, and that can create some lead dust and flakes that pose a risk. Okay, all right, so follow up. So you've already done your lead assessment, food intolerances, and you're still not coming up with something. Patients still come back to you for persistent symptoms. So if the patient met the criteria for IBS and TTG, anti-TTG came back negative, so you're going to consider IBS. And so these are the criteria for Rome for IBS. So recurrent abdominal pain for more than 1 day a week on average in the previous 3 months, with onset more than 6 months before diagnosis. And abdominal pain, and at least 2 of the following. Pain is related to defecation and change in the frequency of stools or change in the form or appearance of stools. And no warning signs. So these are the warning signs. More than 50 years of age, recent change in bowel habits, evidence of overt GI bleeding, nocturnal pain or passage of stools, and intentional weight loss, family history of colorectal cancer or IBD, and palpable mass or lymphadenopathy, or positive fecal occult blood. So this has to be not present, because remember, IBS is a diagnosis of exclusion. All right, so follow up if the patient did not meet the criteria for your IBS, and so you're going down that ladder and still having persistent symptoms. Have you ever heard of this Carnet sign? To be honest, I didn't learn this from school. So I learned this from a program that I purchased, and it's with Hippo. And this is it's a sign of abdominal wall pain. So you elicit this by lifting the head and legs of the patient to flex the abdominal wall. Any worsened or maintained abdominal pain implies an anterior cutaneous nerve entrapment syndrome, and positive tests can indicate abdominal wall pain. All right, so follow up. If you've done everything and there's nothing else is going on, or your labs, Carnet signs negative, so you can consider psychosocial, like anxiety, maybe a psychosomatic manifestation of depression, mental disorder, functional dyspepsia, GERD, or it's related side effect of medication. And so you can still refer the patient to GI so that they don't feel like you're just neglecting them because the workup was negative. So you can refer them to GI. Okay, thank you so much guys for listening. I hope that you found this video helpful. Please consider subscribing to my channel for more content to help you navigate through your first year of being a family nurse practitioner, because I'm excited to share you some tips and tricks and insights with you. All right, so feel free to leave a comment below if there's some specific diagnosis or a complaint that you want me to go over. Okay, so I'm sending lots of positivity, encouragement, and motivation. Take care and see you next time.